Hello, I'm Matthew Cooper, Director of Kidney and Pancreas Transplantation at MedStar Georgetown Transplant Institute and Professor of Surgery at Georgetown University School of Medicine in Washington, D.C. Thank you for your interest in learning more about FCR001, an investigational cell therapy designed to induce immune tolerance that is being developed by Talaris Therapeutics. Today we'll be reviewing its role in potentially improving outcomes in living donor kidney transplant. There are three key topics that will be covered in this presentation. First, I will look at the treatment burden associated with chronic immunosuppression, which is the standard of care after kidney transplant. Then I will review the preclinical data that help us understand how FCR001 works and describe the procedure that has been developed for this treatment. And lastly, I will go into detail on FCR001 Phase 2 clinical trial data and touch on clinical trial design of FREEDOM-1, the Phase 3 trial that is actively enrolling patients. As you know, available treatment options today for patients with end-stage renal disease are limited to transplant and dialysis, and survival probabilities between these options differ. Transplant has been shown to provide lower long-term mortality risk and higher health-related quality of life compared with dialysis. Patient survival probabilities in the United States are more than 2 times higher at 10 years with kidney transplant versus dialysis. In addition to patient survival, graft survival is a critically important outcome. The national data show longer estimated graft half-life and higher median graft survival rates with living donor kidneys compared with those from deceased donors, indicating a potential graft survival benefit with living donor kidney transplant. And despite our efforts and successes in improving one-year outcomes in kidney transplant, long-term graft survival has not increased substantially in the last 20 years. Currently, about 1 in 3 living donor kidney recipients will require a second kidney transplant within 10 years. For those of us in the transplant community, one of the major concerns, without a doubt, is rejection, which accounts for 17% of graft losses in the first year and 63% of losses thereafter. While chronic immunosuppression therapy represented a major investment in transplant by mitigating rejection risk, adherence is paramount. Importantly, studies have shown that kidney transplant recipients who are non-adherent to their immunosuppressive regimens are 7 times more likely to experience graft rejection or loss. In the United States, more than 90% of kidney transplant recipients are maintained on a calcineurin inhibitor, or CNI, based immunosuppression regimen. KDIGO guidelines recommend maintenance therapy with a CNI and an anti-proliferative agent, with or without corticosteroids, beginning prior to or immediately after transplant. Immunosuppression may be reduced 2 to 4 months after transplant if no acute rejection has occurred. In particular, since CNIs can have nephrotoxic effects, minimizing or eliminating their use is an important consideration in balancing the potential increased risk of acute rejection with reduction of side effects. In CNI sparing, or CNI-free immunosuppression regimens that include mammalian target of rapamycin, or mTOR inhibitors, or belatacept are used in some carefully selected patients. When CNIs are used, each dose can cause renal hypoperfusion due to the vasoconstrictive effects on the preglomerular afferent arteriole. Continuous CNI-induced renal hypoperfusion can ultimately lead to chronic changes in the kidney. CNI-related histologic injury in allografts is characterized by obliterative arteriopathy or hyalinosis of the afferent arteriole, ischemic collapse or glomerular scarring, tubule vacuolization, focal interstitial fibrosis associated with macrophage influx, and tubular atrophy. And many of these chronic changes may become permanent. So how common is this damage? Studies show that CNI-mediated histologic injury can be seen on biopsy in most patients using CNIs at some point after transplant. In fact, a single-center study of 119 patients who underwent kidney transplant between 1987 and 2000, all protocol biopsy samples showed signs of CNI nephrotoxicity at 10 years. Patients in this study were maintained on triple immunosuppression with cyclosporin or tacrolimus, plus prednisolone plus azathioprine or mycophenolate mofetil. In addition to CNI nephrotoxicity, chronic post-transplant immunosuppression is associated with a number of other health risks, including metabolic syndrome, cardiovascular disease, neurotoxicity, serious infections, and malignancies. Let's look at each of these conditions in greater detail. Immunosuppression therapy contributes to metabolic syndrome conditions, which are risk factors for cardiovascular disease. Cardiovascular disease is a leading cause of death for kidney transplant recipients with a functioning graft. Risk of graft loss is also increased by more than 3 times in patients with post-transplant hypertension and more than 2 times in patients with post-transplant diabetes. Post-transplant diabetes has been reported in 10 to 74% of kidney transplant recipients. About 1 in 3 transplant recipients experiences neurologic complications, most often due to immunosuppression-related neurotoxicity. Neurotoxicity may be mild, for example, tremor, neuralgia, and peripheral neuropathy, or it may be severe, including slurred speech, vision loss, seizures, cerebellar ataxia, psychoses, and hallucinations. Infection is a leading cause of complications post-transplant. The estimated rate of post-transplant infections is 45 per 100 patient years. Common infections occurring more than 6 months after transplant include pneumonia, viral respiratory infections, and urinary tract infections. Patients who are chronically immunosuppressed may have a compromised vaccine response. Based on recent data, this could include vaccination against the COVID-19 virus. Immunosuppression increases the risk of malignancy, which is the 3rd most common cause of death post-transplant. Squamous cell carcinoma, renal cell carcinoma, post-transplant lymphoproliferative disorders, and other cancers associated with viral infection are among the most frequent malignancies that may occur after kidney transplant. Risk of malignancy is more than 2 times greater at 10 or more years after transplant and in patients who are under 40 years of age at transplant. When you consider the impact of all the risks associated with chronic immunosuppression, the need for an alternative approach to preventing graft rejection becomes evident. What's more, there are effects that extend beyond these clinical implications that are important to consider. Chronic immunosuppression can impose practical and financial burdens on patients and increase the risk of drug-drug interactions. Transplant recipients generally need to take 15 to 25 pills a day for the rest of their lives, and the medication regimen after transplant can be particularly complex for patients who require additional medications to manage comorbidities related to chronic immunosuppression, such as diabetes and dyslipidemia. In a single-center study, 94% of kidney transplant recipients were taking at least 5 different medications a day, which is known as polypharmacy, and 38% were taking at least 10 medications per day. Aside from immunosuppressants, prescriptions for cardiovascular medications are most common in kidney transplant recipients. Notably, immunosuppressants can interact with other commonly prescribed drugs, such as antibiotics, antifungals, and calcium channel blockers through CYP3A or P-glycoprotein inhibition or induction, or other interactions. These interactions can affect immunosuppression efficacy by increasing or decreasing serum concentrations of immunosuppressants. So as I've just discussed, chronic immunosuppression in the kidney transplant population has the potential for clinical repercussions, but may also impact quality of life in transplant recipients. In a small study conducted at Massachusetts General Hospital, kidney transplant recipients who achieved long-term immunosuppression-free allograft survival through human leukocyte antigen, or HLA, haplotype-matched combined kidney and bone marrow transplant required significantly less medication for hypertension compared with patients who were chronically immunosuppressed and did not develop diabetes requiring insulin therapy, dyslipidemia, or malignancies. Patients in this study who were immunosuppression-free also scored higher on assessments of physical quality of life using the Kidney Disease Quality of Life Short Form 36 survey. Another study in kidney transplant recipients showed that poor functional status and depression were associated with lower rates of treatment adherence. The outcomes and risks we've just seen underscore the limitations of standard of care immunosuppression while highlighting the need for advances in transplant. Now I would like to share some background on FCR001, an investigational allogeneic cell therapy and living donor kidney transplant with a goal to eliminate the need for long-term immunosuppressive medications post-transplant. Before I dive into FCR001, let's take a moment to define post-transplant immune tolerance. Simply stated, post-transplant immune tolerance is a state in which the recipient's immune system accepts donor organs, tissues, and cells as self, but is still capable of responding with a normal immune response to other foreign antigens and pathogens. Post-transplant immune tolerance could potentially allow transplant recipients to discontinue chronic immunosuppression. Historically, there have been several challenges to inducing immune tolerance via allogeneic stem cell transplant. The primary difficulty has been the need for an HLA-matched donor. As HLA discrepancies mount, so does the risk of complications such as stem cell engraftment failure and graft versus host disease, or GVHD. Engraftment failure can be associated with high rates of morbidity and mortality. GVHD is another life-threatening potential complication of allogeneic stem cell transplant, in which donor cells mount an immune response against recipient tissues and cells. GVHD may be acute or chronic and may impart lasting effects on recipients. In addition to immunologic complications, patients typically undergo conditioning with various chemotherapies and/or total body irradiation, which may be associated with certain toxicities. The goal of FCR001 is to address some of the immunologic challenges of allogeneic stem cell transplant by creating chimerism, or a dual immune system, in which the recipient's immune system looks partly like the donor and partly like the recipient. A transplant recipient achieves chimerism when their immune cells can coexist with those of the donor in a state of immune tolerance without attacking each other. Chimerism is an indicator of successful stem cell engraftment and may predict whether a transplant recipient can discontinue immunosuppression. FCR001 is a composition of donor-derived CD34-positive hematopoietic stem cells, facilitating cells, and alpha-beta T-cell receptor, or TCR-positive T cells. FCR001 is manufactured from mobilized donor peripheral blood using a proprietary process to achieve a minimum dose of CD34-positive hematopoietic stem cells and facilitating cells, and a range of alpha-beta TCR-positive T cells that is aimed at promoting stem cell engraftment. So what are facilitating cells? Facilitating cells were discovered by Telarus founder Suzanne Ilstad. Preclinical studies have suggested that facilitating cells may have multiple effects on hematopoietic stem and progenitor cells, including enhancing homing and migration to the bone marrow, promoting engraftment, increasing clonogenicity, and inducing antigen-specific regulatory T cells. Now that we have a better understanding of what FCR001 is, let's look at the process by which it is obtained from the donor and administered to the recipient in conjunction with a living donor kidney transplant. To collect and ultimately administer FCR001, both the donor and the recipient must undergo a multi-step process. To mobilize the stem and immune cells necessary to manufacture FCR001, the donor undergoes treatment with granulocyte colony stimulating factor, or GCSF, at least 3 weeks prior to the kidney transplant surgery. The donor's stem and immune cells are collected following mobilization and sent to the Telarus facility in Louisville, Kentucky to manufacture FCR001. Mobilization with GCSF has been associated with adverse events such as bone pain, fatigue, headache, joint pain, insomnia, myalgia, anorexia, and nausea. In the phase 2 trial, no serious adverse events were reported in donors. Once FCR001 is manufactured and passes all quality assurance and quality control testing, cryopreserved bags are shipped to the transplant center. If insufficient cells are obtained in the first collection, the donor may undergo additional apheresis and collection. The donor then undergoes nephrectomy on the day of transplant. The FCR001 recipient also undergoes stem cell mobilization at least 2 weeks prior to transplant. Recipient stem cells are cryopreserved and stored on-site for at least a year in the rare case of bone marrow failure post-transplant. To prepare the recipient for stem cell transplant via FCR001 infusion, a non-myeloablative conditioning regimen is initiated on day -4 prior to the kidney transplant surgery. Before transplant, the recipient undergoes non-myeloablative conditioning with fludarabine on days -4, -3, and -2. Recipients are also given cyclophosphamide plus Mesna on day -3 as part of the conditioning regimen. Conditioning treatments on these 3 days are followed by dialysis 6 to 8 hours after fludarabine. Immunosuppression with tacrolimus and mycophenolate mofetil, or MMF, starts on day -3. On the day before kidney transplant, recipients receive low-dose total body irradiation. And kidney transplant occurs on day 0, followed by stem cell transplant via FCR001 infusion on post-transplant day 1. Recipients receive an additional dose of cyclophosphamide plus mesna each day on post-transplant days 3 and 4. These doses of cyclophosphamide are intended to further mitigate the risk of GVHD and are a standard practice in allogeneic stem cell transplant. And to support the expected hematologic nadir, recipients also begin daily doses of GCSF on day 5, which continue until absolute neutrophil count is greater than 1,000 cells per microliter 3 days in a row. Following kidney transplant surgery and FCR001 infusion, recipients are followed and monitored similar to bone marrow transplant patients, including immunosuppression level monitoring and monthly chimerism testing. At 6 months, the first protocol biopsy is performed. If that biopsy shows no rejection and the patient has no donor-specific antibody or GVHD and also has stable renal function and durable T-cell chimerism of at least 50%, MMF is stopped completely. At month 9, no protocol biopsy is performed, but if the other criteria I just mentioned are met, tacrolimus can be weaned to 0 to 3 nanograms per ml. Finally, at month 12, if all the same criteria are met along with a clean protocol biopsy, tacrolimus can be stopped and the patient continues off all immunosuppression. An additional protocol biopsy is performed at month 24. FCR001 was evaluated in an open-label, single-arm Phase 2 study, which included 36 donor-recipient pairs at Northwestern University Medical Center and 1 at Duke University Medical Center. The primary endpoint was durable tolerance with significant reduction or discontinuation of immunosuppression at 12 months. Donor-recipient pairs were adults between the ages of 18 and 65 years who met eligibility criteria. All levels of HLA mismatching between donor and recipients were allowed. The donor-recipient procedures in the Phase 2 study were very similar to the protocol I described in the last section. A notable difference was that recipients in the Phase 2 study only received post-transplant cyclophosphamide plus mesna on day 3, not on day 4, and instead they started post-transplant GCSF on post-transplant day 4. Recipients are currently being followed for a total of 15 years. As of March 1, 2022, 33 recipients had at least 36 months of follow-up, and 29 had at least 60 months of follow-up. Exposure to FCR001 was approximately 280 patient years. Now let's get to the outcomes seen in the Phase 2 trial so far. 27 of 37 patients in the trial achieved durable chimerism. 26 of these were able to discontinue immunosuppression with no biopsy-proven acute rejection or donor-specific antibody and with stable renal function that has persisted over time. One of the 27 patients who achieved durable chimerism, however, developed GVHD and subsequently died, which I will discuss in greater detail later. Because of the development of GVHD, this patient was unable to withdraw from immunosuppression. As of March 1, 2022, the median follow-up time was more than 6 years. 26 patients had stable chimerism and remained off immunosuppression. 8 patients were transient-like chimeric and were on immunosuppression. Most of these lost donor chimerism within 2 to 5 months after transplant. Factors that were suspected to have contributed to transient chimerism included low number of donor cells, high panel reactive antibody, no post-transplant cyclophosphamide, C. difficile infection, cytomegalovirus or CMV reactivation, an older donor, and hemolytic anemia. Among transiently chimeric patients who remained on immunosuppression, 5 experienced rejection, 3 had graft losses, and 1 died. 2 patients who failed to engraft and did not achieve chimerism remain on immunosuppression. Failure to achieve chimerism was suspected to be associated with high panel reactive antibody in 1 patient and an underlying bone marrow disorder, large platelet syndrome, in the other patient. Now let's take a closer look at the 26 durably chimeric patients who discontinued immunosuppression. At the March 1, 2022 data cutoff, 5 of 26 were immunosuppression-free for more than 10 years. Interestingly, when the role of HLA matching was examined in these 26 recipients, no correlation was observed between the degree of HLA match and the achievement of durable chimerism plus discontinuation of immunosuppression, or with the incidence of GVHD or other safety outcomes. In 19 patients, or 73%, matched with their donor at 3 or fewer HLA loci out of 6. Bidirectional recipient and donor matching was also evaluated for 32 pairs from the Phase 2 study, including 25 recipients who were off immunosuppression. High-resolution allele typing for HLA-A, B, C, DRB1, DQB1, and DPB1 was performed for all but 3 pairs that only had enough DNA to type 10 of 12 alleles. All recipients had reached at least 4.5 years of follow-up, with a median of more than 6 years and a maximum of more than 12 years of follow-up. Once again, there was no correlation between the degree of HLA match and durable chimerism, GVHD, or other safety outcomes. Now let's take a look at donor chimerism. The presence of donor chimerism during the first year after FCR001 facilitated transplant was identified as a possible predictor of durable immune tolerance. For the purposes of this study, persistent donor chimerism of at least 50% donor T cells at 3 and 6 months was used to guide tapering of immunosuppression. As you can see here, mean donor chimerism in patients who were off chronic immunosuppression at 1 year was about 90% from month 2 onward, meaning that about 90% of the recipient's T cells were donor-derived. 26 of 29, or 90%, of patients who were chimeric at month 3, and 26 of 27, or 96%, of patients who were chimeric at month 6 discontinued immunosuppression at month 12. And all 26 of these patients remained off immunosuppression for a median of more than 6 years and a maximum of more than 12 years of follow-up. Now let's take a look at some additional analyses that evaluated the impact of FCR001 on post-transplant health. The Phase 2 study did not include a control arm, so a retrospective analysis of matched controls was performed comparing renal function and cardiovascular medication use in FCR001 recipients with a comparable standard of care population. The standard of care population consisted of 132 patients who underwent standard living donor kidney transplant at Northwestern University Medical Center between 2009 and 2012, who met FCR001 Phase 2 eligibility criteria and were on lifelong immunosuppression. Retrospective analysis of estimated glomerular filtration rate, or eGFR, showed preserved renal function for up to 5 years in the FCR001 Phase 2 group, while renal function declined in the standard of care group over time. For patients who discontinued immunosuppression, mean eGFR was 66.1 mils per minute per 1.73 meters squared at 5 years. Mean renal function calculation excludes graft losses occurring prior to a given time point. Because of the retrospective nature of this analysis, 1 month and 5-year data were not available for the standard of care group. In the same retrospective analysis, rates of hypertension medication use were 18% and 83% for the FCR001 and standard of care groups respectively at 4 years post-transplant. And rates of hyperlipidemia medication use were 9% and 43% for the FCR001 and standard of care groups respectively. Another area of interest in kidney transplant is recurrence of autoimmune kidney disease, which can contribute to graft loss. Of the 7 patients who were durably chimeric and who were indicated for transplant due to autoimmune kidney disease, none have experienced recurrence at median follow-up of more than 6 years. However, among non-chimeric or transient chimeric patients, IgA nephropathy or membranous glomerulonephritis recurred in 1 patient each. Notably, recurrence rates of these autoimmune kidney diseases in the general kidney transplant population ranges from 8% to 55%. These findings in the Phase 2 study are interesting, but will need to be evaluated in a larger cohort. Other important immunological questions are, what does the immune system look like after non-myeloablative conditioning and facilitated allogeneic stem cell transplant with FCR001, and does the recipient reconstitute an active immune system? To address this, overall leukocyte and T cell subpopulation recovery were evaluated in the first 12 patients in the Phase 2 study who maintained chimerism. Here we see that the counts for CD3 positive T cells, CD19 positive B cells, CD56 positive natural killer cells, and CD14 positive monocytes decreased after conditioning and transplant, but started to recover within 3 months. And looking more closely at T cell subpopulations, we see that CD8 positive cells recovered more quickly than CD4 positive cells, and that memory phenotypes of both CD4 positive and CD8 positive T cells were dominant over naive T cells. Most importantly, these results indicate a full immune reconstitution following FCR001 therapy. Now that we have reviewed some of the efficacy outcomes in the Phase 2 trial, let's take a closer look at the safety findings. As previously mentioned, 3 graft losses occurred in the Phase 2 trial. In all cases, immunosuppression was markedly decreased because of severe infections, which resulted in acute rejection in 2 patients and ultimately graft loss. One graft loss occurred in a patient who had graft thrombosis during a viral sepsis episode. This patient was hypotensive, hemodynamically unstable, and required continuous veno-venous hemofiltration. The second graft loss was in a patient who experienced sepsis that did not respond to antibiotics. Complete interruption of immunosuppression was required to address the infection. The third instance of graft loss was in a patient who lost donor chimerism 4 months after transplant, secondary to CMV reactivation. The patient continued immunosuppression and was switched to belatacept at month 26 because of calcineurin inhibitor nephrotoxicity. Immunosuppression was later reduced because of recurrent CMV, BK viremia, and a Pseudomonas infection, and the patient subsequently experienced acute cellular rejection and chronic antibody-mediated rejection. Dialysis was initiated after decline in renal function was observed. Biopsy-proven acute rejection occurred in 7 patients, 5 of whom were transiently chimeric and 2 who were never chimeric. 6 of these patients were maintained on lower than normal levels of immunosuppression, and 4 were maintained on monotherapy with tacrolimus or sirolimus. No acute rejection or de novo donor-specific antibody occurred in patients off immunosuppression. FCR001 infusions have been well tolerated with no infusion-related reactions. Most adverse events occurred during the first 12 months post-transplant while patients were on conventional immunosuppression. The most common adverse events occurring in more than 20% of patients were diarrhea, BK viruria and viremia, fever, cough, and nausea. The most common severe adverse events occurring in more than 5% of patients were fever, deep vein thrombosis, diarrhea, pneumonia, and febrile neutropenia. The most common infections were BK viruria and viremia, nasopharyngitis, cellulitis, upper respiratory tract infection, and urinary tract infection. GVHD is a notable and potentially life-threatening adverse event associated with allogeneic stem cell transplant. In the FCR001 Phase 2 study, acute GVHD occurred in 2 durably chimeric patients. One patient with grade 2 GVHD was treated with steroids and is now off immunosuppression but has chronic GVHD with ocular and musculoskeletal symptoms. One patient with grade 3 GVHD presented late with diarrhea and had a protracted course of GVHD that was complicated by tissue-invasive CMV colitis and infection. At approximately 11 months post-transplant, the patient's condition deteriorated after developing a pulmonary process of undetermined etiology. He ultimately developed septic shock, which progressed to multi-organ failure and death, which is the worst possible outcome of GVHD. Overall, patients who received FCR001 and achieved durable chimerism had a slightly lower 5-year survival rate compared with living donor kidney transplant recipients in the United Network for Organ Sharing database. However, the small sample size in the Phase 2 trial makes comparison difficult and does not allow statistical comparison with national data. 3 deaths occurred in durably chimeric patients at 11 months, 3.5 years, and 4.5 years. The death at 11 months was in the previously mentioned patient with grade 3 GVHD. The death at 3.5 years was from pneumococcal sepsis in a subject traveling abroad who was non-adherent and was not revaccinated per stem cell protocol. The death at 4.5 years was from a lung cancer and a heavy smoker. One death occurred in a transiently chimeric patient 4.5 years after transplant because of candidiasis and respiratory failure, secondary to septic shock and aspiration pneumonia. Of course, donor safety is also a key consideration as part of this therapy. In the Phase 2 study, adverse events reported in donors were mild to moderate, and no serious adverse events were reported. Donor adverse events were consistent with standard stem cell mobilization and GCSF: headache, fatigue, musculoskeletal pain, and nausea. Adverse events occurred around the time of GCSF administration for stem cell mobilization and apheresis. Based on outcomes in the Phase 2 trial, a Phase 3 trial called FREEDOM-1 has been initiated and has started enrolling patients. In this section, I will review the design of that study. FREEDOM-1 is a randomized, controlled, multicenter Phase 3 study of safety and efficacy of FCR001 versus standard of care immunosuppression in de novo living donor kidney transplant recipients and safety in FCR001 donors. The primary endpoint is proportion of FCR001 recipients who are free from immunosuppression and without biopsy-proven acute rejection at 24 months post-transplant. A key secondary endpoint is change in renal function in FCR001 recipients as measured by eGFR from post-transplant baseline at month 1 to month 24. In FREEDOM-1, the FCR001 protocol is largely the same as that in the Phase 2 study, but includes 2 doses of post-transplant cyclophosphamide plus Mesna on days 3 and 4. In the standard of care arm, donors undergo nephrectomy on the day of transplant. Recipients will be placed on immunosuppression after transplant according to a standard of care protocol including antibody induction, tacrolimus, and MMF, and recipients in both study arms will be followed for 5 years post-transplant. Recipients in FREEDOM-1 must be at least 18 years of age and undergoing a first or second kidney transplant from a living unrelated or related donor who is not an identical twin. Donors must be 18 to 60 years of age and willing to undergo mobilization, apheresis, and 12-month safety follow-up. Exclusion criteria for recipients include panel-reactive antibody greater than 80%, ABO incompatibility, and presence of donor-specific antibody. Male recipients of a biologically unrelated female donor kidney are also excluded. Exclusion criteria for donors and recipients include history of malignancy within 5 years of screening and known bone marrow aplasia. Clinical updates for FREEDOM-1 may be provided periodically on the Talaris Therapeutics website. In addition to de novo living donor kidney transplant, FCR001 is being investigated in patients who have previously undergone living donor kidney transplant. This clinical trial investigating this use of FCR001 is called FREEDOM-2, and in this section I will review the study design. FREEDOM-2 is an open-label, single-arm, proof-of-concept study of FCR001 safety and efficacy in patients who underwent living donor kidney transplant 3 to 12 months prior to enrollment. The primary endpoint is proportion of FCR001 recipients who are free from immunosuppression and without biopsy-proven acute rejection at 24 months post-FCR001 infusion. A key secondary endpoint is change in renal function in FCR001 recipients as measured by eGFR from day 1 prior to FCR001 infusion to month 24. The FCR001 protocol for FREEDOM-2 is similar to FREEDOM-1, except that all FCR001 steps take place after kidney transplant. FREEDOM-2 does not include a control arm. Recipients will be followed for 5 years post-FCR001 infusion. Recipients in FREEDOM-2 must be at least 18 years of age and must have undergone a first kidney transplant from an unrelated or non-HLA identical related living donor 3 to 12 months prior to signing informed consent. Recipients must also have stable allograft function with eGFR of at least 60 mL per minute per 1.73 meters squared at screening and less than 25% decrease in eGFR between the last 2 consecutive visits. Donors must be 18 to 60 years of age and willing to undergo mobilization, apheresis, and 12-month safety follow-up. Exclusion criteria for recipients include panel-reactive antibody greater than 80%, induction with alemtuzumab at the time of kidney transplant, history of suspected or biopsy-proven acute rejection or disease recurrence, and oral corticosteroid use. Male recipients of a biologically unrelated female donor kidney are also excluded. Exclusion criteria for donors and recipients include positive cross-match at screening, history of malignancy within 5 years of screening, and known bone marrow aplasia. In closing, I hope that this video has helped illuminate some of the drawbacks of chronic immunosuppression. We also reviewed FCR001 as an investigational cell therapy with a goal to establish durable donor chimerism and withdrawal immunosuppression in kidney transplant recipients. FREEDOM-1 is designed to build on the Phase 2 study, providing additional data on safety and efficacy in recipients compared with standard of care and safety in FCR001 donors. And FREEDOM-2 will help us determine whether FCR001 could eliminate the need for chronic immunosuppression in patients whose living donor kidney transplant occurred up to a year before enrollment. If you would like to learn more about FREEDOM-1 or FREEDOM-2, which are both open and enrolling patients, please visit our Clinical Trials Overview site or the NIH Clinical Trials site. Thank you for your time and your commitment to kidney transplant.